This is Willie Kemp. This is my fifth lecture on anemia. This is Conditions Causing Increased Destruction, Part 3. There once again are web pages for me and Dr. Hughes, as well as my Twitter handles, which, like I said, I haven't posted in a long time. My stuff is still up, and I might start doing that again. And like I said, once again, I'm a forensic pathologist, but I have a really strong interest in general and organ pathology, i.e. non-traumatic pathology, and I very much enjoy teaching medical students. I have 3 disclaimers for the lectures. If you pause, read it. If you don't agree with it, then please stop viewing the lecture. If not, please continue. There's a 3rd disclaimer. Once again, pause, read it. If you disagree with it, please stop watching the lecture. And then the last one is I made a short lecture, just kind of an introduction to me, my teaching style, and what I do and stuff like that, so you can kind of understand what I'm doing. But here are the references I used for all the lectures. Once again, really great books. I don't have any financial connection to any of them. So, like I said, this is part 3, specific conditions leading to increased destruction of red blood cells. Number 3, mechanisms: loss, either acute or chronic, increased destruction, and decreased production. And the last 2 lectures will be decreased production. So we're going to talk about immunohemolytic anemia, the basic features of it. So as far as etiology of anemia, it's an extravascular hemolysis. So basically, almost always, if you had a transfusion reaction and you had a antibodies against that cause lysis cell immediately, you can. So if you have an ABO incompatibility, that can cause intravascular hemolysis, very serious condition. But for the most part, antibodies will bind the red blood cell and then they get removed in the spleen, and so extravascular hemolysis. You can either have a warm antibody or a cold antibody if it's autoimmune. But remember, there's also non-immune forms. There's immune but non-immune forms, and blood transfusion reaction would be one of them. Mechanism: antibodies usually triggered by drugs or infection or neoplasia, and they can also occur spontaneously. Pathology: you can see spherocytes. So once again, you can see hereditary spherocytosis. You can see spherocytes, but also in a warm autoimmune hemolytic anemia. Basically, kind of the idea is that, to me, is that the immunoglobulin coats the red blood cell, and kind of basically the body chews away a little bit at a time, and it kind of shrinks it in size. And then since it's extravascular hemolysis, you're going to have increase in size of the spleen. Remember, hereditary spherocytosis, you can have a spleen that's normally around 150 grams be 500 to 1,000. So the 2 main forms are warm antibody hemolytic anemia, cold antibody hemolytic anemia, and I've seen warm autoimmune hemolytic anemia, cold autoimmune, and then cold antibody, warm antibody. So, unfortunately, names kind of change around, but same idea. So warm antibody hemolytic anemia can be primary or idiopathic. It can also be secondary to various drugs, autoimmune disease, or neoplasms, whereas cold has acute or chronic. In acute, it's usually due to infection, usually mycoplasma or Epstein-Barr virus. In chronic, it's oftentimes idiopathic or can be due to B-cell lymphoid neoplasms. In warm, it's IgG, sometimes IgA. In cold, it's IgM. And this can be very important because in warm, the reason it's called warm is IgG and IgA bind at 37 degrees. But in cold, IgM binds at less than 30 degrees. So that's why it goes along with the 2 there. The mechanism by which an warm antibody hemolytic anemia forms, it says either that you can have autoantibodies form against red blood cell antigens, because you have tons of antigens on your red blood cells, or the substance can act as a hapten and binds the red blood cell antigen and induce antibody production, or you can have an antigen-antibody immune complex. What happens in cold is that the IgM, which binds at less than 30, fixes complement, and then after it reaches 37 degrees, the IgM falls away, leaving the complement, and then C3b acts as an opsonin, and then the red blood cell gets phagocytized. So when we're talking about autoimmune hemolytic anemia, an important testing modality are the Coombs test. There's both a direct and an indirect. So at direct, what I have here is that to the left you have the patient's red blood cells, which I made blue, but they have the little black antibodies on it. So what happens is you're testing for those antibodies. So you add the red antibodies which binds to the black antibodies, which causes agglutination. That's a direct Coombs test. So you're seeing if there's any antibodies on the red blood cells. Whereas an indirect Coombs test, you assume there are antibodies in the serum, but not on the red blood cells. So you add red blood cells to have those antibodies bind to it, and then you add the red, and the black and red is just me for demonstration purposes, okay? But then basically you add the red blood cells so that the antibodies in the serum, in the plasma bind to it, and then you add antibodies to those antibodies, and then they will cause agglutination. So it's kind of just like an extra step. So those are the direct antigen and the indirect test. So with Coombs testing, if it's positive, it can be positive for a couple things. It can be positive for IgG, it can be positive for complement. If it's positive for both or positive for IgG and not complement, it's either a drug-induced or a warm autoimmune hemolytic anemia. Whereas if it's IgG negative or anti-IgG negative, but complement, then there's a good chance it's a cold agglutinin. So you do a cold agglutinin titer. If that's negative, then it's probably just some version of drug-induced or warm autoimmune hemolytic anemia. But if it's positive, then it's a cold autoimmune hemolytic anemia. If the Coombs testing on a hemolytic type anemia is negative, that means it's probably a intrinsic defect in the red blood cell. So this goes back to the Coombs testing would be what you would do to help work up if you think it's immune mediated. But if it's not immune mediated, then you'd have to start looking for what else might be causing the red blood cell to hemolyze. So could it be target cells as you see in thalassemia, sickle cells you see in sickle cell, spherocytes, hereditary spherocytosis, schistiocytes in microangiopathic hemolytic anemia, Bite cells or Heinz bodies in glucose 6-phosphate dehydrogenase, or do you see intracellular parasites? So the idea here is this is what you do with a differential if you have hemolysis and you suspect it's immune mediated, but then it shows you what happens if the Coombs is negative and it's not immune mediated. So I thought I'd also just show kind of the mechanism of cold antibody hemolytic anemia. This time I made the red blood cells red. So with the red blood cells being red, they have IgM bound to them, and that binds at less than 30 degrees Celsius. Okay? But it also binds C3b. Then once the red blood cells warm up, the IgM falls away, but it leaves that C3b. And then that C3b acts as an opsonin, so the cells get phagocytized away in the spleen, i.e. the extravascular hemolysis, and the resulting splenomegaly. And that's the way a cold antibody hemolytic anemia works. So one thing it says about with an immune hemolytic anemia, the IgM is pentavalent, so it has 5 little points on it. So it can really agglutinate the red blood cells. And what that can do is that can lead to real bad sludging of the red blood cells, and you can actually see something like a Raynaud's phenomenon because of it. Okay, so here's my slide for halfway, or relatively halfway. This is a porcupine. I think it was in the Billings Zoo, I think. It's amazing because they always just look like you could just pet them, but you really wouldn't want to. Okay, so I think one of the last things we'll talk about with, or almost one of the last things, is mechanical trauma of the red blood cells. This can cause hemolysis. So heart valves are known to do it. Like I said, my understanding is the newer heart valves that have been around since I've been in medical school, I think, are usually don't. It was the older ones, but sometimes if you have a malfunctioning valve, it could. Another one I read, it said actually repeat physical trauma can do it. So marathon running, things like that, where you're, I guess, pounding the same part of your body over and over and over could traumatize the red blood cells and cause them to break up. Also, if you have something like a microangiopathic hemolytic anemia, so something that you see in TTP or HUS or disseminated intravascular coagulation, DIC, where you basically have blockage with little microthrombi within the microvasculature. When the red blood cells move by, they kind of get sheared and then they break up, and then you get schistiocytes, fragments of red blood cells. So here are the schistiocytes. The black arrows show them. This is a patient with TTP. I've actually seen TTP at autopsy a couple times, and it's amazing. I think peripheral blood smears are not utilized very commonly at autopsy, but I've used them a couple times and had some interesting stuff. One time when I was doing hospital ones, though, I looked at some cells and like, oh my gosh, it looks like cancer. It was the mesothelial cells from the lining, so when I used the rib. So this is the last one. Infections can also cause hemolysis. So malaria and kind of the North American version of babesiosis. So malaria, these come from the Bionopheles mosquito, and humans are the only known host. There's several genus, and there's several species of it. Plasmodium falciparum is the most lethal. Plasmodium malariae, vivax, knowlesi, and ovale are much more benign. And so what happens is you get episodic fever with chills, and those chills and shaking correspond with release of merozoites, and there's different timing for the different species. So it causes an intravascular hemolytic anemia. The parasites are in the red blood cells in the blood flow, so it can break that up. So remember, something you would see would be a urine hemosiderin. You see hemosideриnuria, hemoglobinemia, and then you see urine hemosiderin. You can also see malarial pigment, which is derived from the hemoglobin. You can see that in the liver, lymph nodes, bone marrow, and that. And then splenomegaly, sometimes hepatomegaly. Here's malaria. To the left of it, you see the little headphones there in the red blood cells. And to the right of it, the pigment that you see all over is malarial pigment. This was a person who died in the hospital with malaria. They had, I think they had CNS changes as well too. It's not formalin pigment. So you can get a cerebral malaria due to Plasmodium falciparum involving small vessels of the brain. The mechanism is there. Normally the red blood cells are negatively charged, but they become positively charged by the parasite. That kind of leads to sluggish blood flow. And in the brain, that's not good. And they can lead to convulsions, coma, and can be fatal. And then black water fever, you have massive intravascular hemolysis. So you get hemoglobinemia, hemoglobinuria, and jaundice, and that kind of was where I guess the black water comes from. Maybe it's like your urine gets so discolored from it. So once again, use reflection, pause, ask yourself, okay, what are 5 things I learned from this lecture? And like I said, I hope you learned 5 things. And this is a really good way to remember the material and kind of cement it in your mind. So I highly recommend doing this. So here's the groundhog. He's not groundhog. Well, prairie dog. Sorry. He doesn't look very excited. He looks kind of bored. But I'm hoping you all are not bored and that you found this information useful. And I hope this helps your understanding of anemia. Thank you.